Good afternoon. My name is Dr. Michael Koren. I'm the CEO and an investigator here at Jacksonville Center for Clinical Research.
And I'm Vicki Mosteller, and I am a medical director here at Jacksonville Center for Clinical Research.
And thank you so much for joining us. This is a monumental time for us because we are actually responding to the COVID-19 pandemic, and we're inviting people from our community to come into our beautiful conference center and actually have an interaction. But not just anybody can get into this conference center today. So first of all, to get into this conference center, you need to be vaccinated against COVID-19. So who has been vaccinated against COVID-19? All right, 100%. That's terrific. The other thing is that we're staying a little bit distant. Everybody's at least 3 feet apart from each other. And we are also staying 3 feet apart from each other. No kissing, even if you want to. And, but this is an opportunity for us to have medical education where you folks can ask us, the experts, questions, and we'll also have a Zoomosphere audience out there that can see what's going on in terms of us interacting with you. They may have their questions. They'll be able to formulate those questions and ask those at the end. But ultimately, we want to have an experience where we meet your needs, that we learn together about heart disease and particularly cholesterol issues. So I'm really excited about the program today. Vicki, do you want to drive?
So our format that we're going to use is med evidence. And again, the whole idea behind med evidence is that we're going to use evidence to tell you medical information, not somebody's opinion on the subject. So what do you think med evidence is beyond that? An educational program led only by physician scientists to explore medical trends and breakthroughs? Or a hybrid learning experience, both in person, live, and virtual? Maybe it's a Socratic teaching method combined with modern learning, kind of using the old plus the new. Or an exploration of real data with experts? Maybe all of the above.
Okay,
what
so
do you
now
think?
You guys got to do some work now. Who says it's 1? Who says 2? Oh, we got one person out there. Who says 3? Who says 4? And who says 5? All right, you see the wisdom of the crowd, they got it right.
Yes.
That's pretty amazing. And there you go, the answer is all the above. So the meta-evidence concept is to put all these elements together for an amazing learning experience. So one of the things that's interesting, no one heard of meta-evidence before you got here? No one heard of it. But despite the fact that you had never heard of it, you were able to answer a very sophisticated question correctly. Think about that, it's pretty cool. How were you able to answer that question correctly? Because you have knowledge. You have knowledge about the way the world works, and you have knowledge about the basic presentation when you came in here, and you're able to answer a very sophisticated question. And that's the point of the Socratic method. It gives us the opportunity to use each other to learn more, to bounce ideas off of each other, to take our pre-existing notions and to test to see if they're correct. So the Socratic teaching method, who has heard of that before? Okay, about half of you. It's funny, that's the way education was for many, many years. If you remember, what's the name of that movie? The Paper Chase? Yeah, about the law school where the mean law professor would intimidate the students and ask them questions and they have to come up with the answers. And that was a movie and it was a TV show. And it got a little bit of a bad name because it was looked at as a way of intimidating. But actually, it's a really good way to learn as long as the leaders aren't jerks.
So don't be a jerk.
Okay, thank you. So it's a good way because everybody in the room has some elements of knowledge and some things that they don't know that probably other people don't know. And unless you do the communication, you don't know where you stand. So at the end of the day, you get a much richer learning experience. So again, the definition is a form of cooperative, argumentative dialogue between individuals based on asking and answering questions to stimulate critical thinking and to draw out ideas and underlying presuppositions.
And who is that guy?
Oh, this guy on the screen?
Yeah.
I think he was a guy in my waiting room that was waiting a little too long. No, that's Socrates. He actually spent some time in prison, so hopefully we'll get out of here without interacting with the police. Anyhow.
Or freezing.
Go ahead, Vicki. Why don't you take over?
All right. So what was the leading cause of death in the U.S. in 2020? And it was a big year. Lots of deaths. lots of news in the media about deaths. And what was the number one cause of death? Does anyone want to take a gander at it before we go through some of the choices? COVID.
All
Okay.
right.
Anybody
It's
else?
like, remember Family Feud, like it pops up. That's the number 6 answer.
Yeah.
Heart
I was
disease.
going to say cardiovascular disease.
Cardiovascular disease,
Any
heart
other
disease.
guesses?
Cancer.
Cancer, all right.
Okay, those are all.
You guys are
those
pretty
are
good.
there.
Well, those are all part of the choices.
So was it cancer? Was it heart disease? Was it COVID-19? Maybe it was nagging spouses, nagging husbands, huh?
Well, you know,
It's
that'd be
really nagging husbands. Women never nag, right?
Well, that would be heteronormative of you, so we'll call it a name.
Politicians. Politicians. So what is the real answer here? Heart disease.
Heart disease.
And let's see.
You don't believe us, do you?
So very interestingly, we're right, it is heart disease, and yes, we do have data. You can see it here. Heart disease was 1 at 690,000, nearly 600,000 for cancer, and 345,000 for COVID, which is still a big number. But the most interesting thing here is, of course, COVID went from 0 to 345, but cancer has remained relatively constant at just below 600,000, whereas heart disease has gone from 633,000 to 690,000, yet we're supposedly smarter in 5 years. And so it is the number one cause of death by a substantial quantity, 20% more.
Yeah, it's a concerning trend that it's going up, whereas cancer is stable. And of course, COVID is hopefully a one-off issue that we're dealing with this year and next, at the worst. So there's actually both good news and bad news when we talk about cardiovascular disease. So the good news, when you look historically, is over the last 20 to 30 years, there has been a dramatic reduction in heart disease deaths. And as a matter of fact, the peak was somewhere around 1980, and from 1980 to around 2010, heart disease deaths dropped by 50%, which is a really remarkable achievement, and we'll look at some of the reasons why. The bad news is it's still the number one cause of death in the country, as mentioned. 92 million Americans are affected by it. There's one death every 40 seconds in the U.S. About 60,000 people die of heart disease every month, and it's projected to rise by 46% over the next decade, which is very, very concerning. So despite our advances, despite the fact that we can do things that we couldn't even dream of 10, 20, 30 years ago, we're still fighting this pandemic. This is truly the other pandemic, and my belief is that this pandemic will persist even after we conquer COVID-19, which will hopefully be sooner rather than later. And if you actually look at the numbers in more detail, you get a real picture for how well we have done over the last couple of decades and how we're kind of stuck. So if you look at on the left side of the slide, you'll see that in the 1950s to 1960, we had very high rates of cardiovascular disease, CVD, coronary heart disease, CHD, and stroke. And these are now looking at the death rate per population that's age adjusted. So if the population is having these events at an older age, that counts less than if they have it at a younger age. So between, let's say, 1970 and around 2010, we see things dropping very, very nicely. As a matter of fact, for overall cardiovascular disease, there was a drop, as I mentioned, of well over 50% around the country. But when you look into the data a little bit differently, it's not quite as rosy a picture. So here you can see total cardiovascular deaths. Now this isn't a rate, this isn't adjusted for anything. These are the actual number of people who are dying each year in the US. And you can see it went up pretty substantially between the beginning of last century and around 1960, 1970. And then it plateaued, and again, the population's still rising, so when it's plateauing, keep in mind that the rate is still going down, even though the total number is about the same. And it actually took a dip down nicely between 1980 and about 2010, but unfortunately, since 2010, the numbers are going back up again. And there have been tremendous advances to treat heart disease over the course of the last 100 years, as you can imagine. Our first recognition of the problem really came to fore shortly after World War II during the Framingham Heart Study, where we identified the many cardiovascular risk factors that you're familiar with, which we'll be talking about today. And those include cholesterol and hypertension and cigarette smoking. And we've certainly done a lot to address those over the years. I would say that the years between the 1950s and the 1980s were the glory years for anti-hypertensive medications. So we developed diuretics and ACE inhibitors and beta blockers and calcium channel blockers, which have had a huge impact in terms of reducing heart disease and stroke. But they're not the end all. Then we got into the early 1990s and we developed the statin drugs, which had a huge impact. In fact, if you look at the introduction of the statin drugs in the early 90s, for the next 10 to 15 years, there was a big drop in the number of deaths. Of course, on the top of the slide, while we were developing all these drugs, we were also developing faster ways of getting people to the hospital. So our EMS system is better. Once they get into the hospital, their heart attack is identified faster. We get them to the cath lab, we do stents, we do resuscitation. We have all types of ways of keeping the stents open. We have all these interventions that we work with in the hospital. So that's been getting better over the years as well. And then in 2015, we started adding biological agents to treat cardiovascular risk factors, and these are called PCSK9 inhibitors, and I'll talk a little bit more about that momentarily. But you can see, despite all this technology, we're seeing an uptick again. So we need to refocus. We need to refocus as a society and get back on track. Vicki, you might have a comment about this.
Yeah, and so again, it's very interesting. As we talked about, there was a dramatic fall, and so we started introducing these things in the 90s. You see everybody, the men were falling. The women, however, didn't recognize that fall until the 2000s, and that has to do with the fact that a woman's heart attack is a little bit different. She just kind of has low-level heart attack and then may suffer another one, et cetera, whereas men tend to have more dramatic symptoms of that clutching of the heart, and therefore they get those interventions he talks about of getting to the ICU, getting that stent placed, getting that cath, whereas a woman might just be identified as, oh, maybe you have a little blockage. And so it wasn't until they began to realize that a heart attack is a heart attack is a heart attack that we began to start getting some of the interventions that they offered to the men, such as the statins and some of these other things.
So let's put the audience back to work, what do you think?
Mm-hmm.
You want to read the question?
So if you've had a heart attack and you're stabilized in the hospital, who's at highest risk for another event in the next 1 to 5 years? Are men higher than women? Or are women higher than men? Or are the ones who have been on statins prior, are they actually more likely to have another one than somebody who hadn't been on statins and now we start them on statins? Or the patients that actually are so bad they have to go to cardiac rehab? Which one of those do you think is most likely to have a heart attack in the next 1 to 5 years? Anybody want to guess? Women? What do you think? Women? Anybody else?
So let's do a show of hands.
The rehab?
Who says men have a higher risk than women of a recurrent event? You have 3 people.
All right, 3.
Who say women are higher than men for a recurrent event? 3, okay. Who say, and this is after a heart attack, statin users after a heart attack versus people that have a delay before they get on lipid drugs? Okay.
2, okay.
And who says cardiac rehab patients?
2, okay.
And the answer is women higher than men. You want to comment on that?
And part of the reason that that happens is, like I said before, women don't have cholesterol hardening of the arteries that begin as soon as you go through puberty. In fact, that's more of an issue later on in life, post-menopause. We have nice soft linings in our blood vessels, so we don't get those big clogs and those, hard arteries right from the beginning. So we don't get that clutching. And then we can still kind of eke along. I think it has to do as well, I don't know statistically, with the fact that we tend to poo-poo our own symptoms and work through that pain. And so, not like those, wimpy men. But
well, we all know that women are tougher than men. That goes without saying.
But it also has to do with the type of heart attacks that we have. So do you want to address that?
Sure. So you can see on the right side of the slide, there's something that says STEMI. And that's not the name of my old girlfriend, in case you thought that might be. But it actually stands for an ST elevation MI. And the EKG there shows the characteristic of the EKGs when people come in with that particular problem. And as Dr. Mosteller mentioned, that's much more common in men than women when they present. So those are people that get identified quickly. They go to the heart cath lab. They hopefully have one artery only that needs to be fixed, and they get a stent to fix the problem. And that's different than what's called a non-STEMI or non-ST elevation MI, where it's more diffuse, the disease. It may not be as clear that you're having a problem when you start, and the solution may not be just one spot. So men and women do present differently, and it's a great point. The Framingham data, which we mentioned before, came out with some numbers, some years ago, but still relevant, that once a man has a heart attack, the likelihood of having another event over the next few years is about 13%. For women, it was 40%. Huge difference. So for that reason, we like to remind women that their symptoms may be a bit atypical, but they should be taken seriously. Statins are great drugs. Every time we look at the use of statins, the higher the dose, the better. The faster you use it, the better. And cardiac rehab is actually one of those things that can save lives. So sometimes people are reluctant to dedicate time to a cardiac rehab setting after a heart attack, but certainly I would recommend it, and it's something that's been proven in studies to make a big difference.
All right, so we're talking about all this heart disease. So what is your heart disease risk, and how much of that risk could you take care of with your actions versus how much of that risk is genetic and you can't do it on your own? You need to have an understanding of it and possibly some therapeutic interventions. So let's look at those things. What kind of things are your actions? You can adjust the lipids by taking care of your diabetes, being overweight and obesity, not having physical activity, unhealthy diet, smoking, high blood pressure. Those are risk factors that you can take care of. Go ahead. And then he'll talk about some of the cholesterol was the first thing on there, taking care of your cholesterol. What are some of the things that cholesterol can cause?
And that's going to be our focal point for discussion today. Who here has a cholesterol problem or concerned about a cholesterol problem? Okay. Who here has a family member that they're concerned about with a cholesterol problem? Okay. So between personal experience and family members, virtually everybody in the room has touched this because it's a very common problem. And the good news is that, as Dr. Mosteller mentioned, we can actually do a lot to deal with cholesterol problems. But just so everybody's on the same page, cholesterol problems can cause some very, very specific issues. They actually can cause cosmetic issues. Have you ever seen people that have like yellow spots underneath their eyes, like a yellow deposit, a waxy deposit? Well, those are called xanthomas, and it can happen under the eyes, it can happen on the elbows, it can happen on the legs, and so sometimes it's a cosmetic issue. But the more serious things tend to be issues that affect the heart and the brain. So angina is the word that we use for the type of symptom you get when your heart arteries are blocked. Angina is actually a Greek word going back to Socrates that means choking. So it's not necessarily a pain, and often when I talk to my patients and I'm saying, do you have chest pain? They say no, but then you get into a little bit more discussion. Oh, I have this sense I'm suffocating. Well, that could be angina. And again, the Greek translation of the word angina means choking. Heart attack is when you actually have heart muscle that's damaged by the event. So typically we develop atherosclerosis, which is hardening of the arteries. At some point that progresses to a point where that plaque, that hardening of the artery, can crack and cause a blood clot. And that suddenly reduces the blood flow and oxygen to a part of the heart, and that causes a heart attack. That can result sometimes in relatively small amount of damage. It can result in large amount of damage and congestive heart failure, or it could kill somebody. And then if you get a blockage or a problem in one of the arteries that goes to the brain, that would cause a stroke. All these things can be related to high cholesterol. So why don't you run through what cholesterol is for everybody in more detail, Vicki?
All right, so it's a waxy fat-like substance, and the important thing is it's found in every single cell in the body, even in your eyelashes. And it's so important to the function of all of the cells that every cell in the body makes cholesterol from the components that make up cholesterol, because it's part of every cell wall. And we don't make it, however, in our eyelashes. We just have it in our eyelashes. But other than that, every cell does make it. And the problem is that we either eat too much of it or we have a problem where we make too much of it. And we have to make it. We can't not make it because we just said it's in every cell in our body. So there's a fine line between that making it and making too much of it and causing a problem. And the serum cholesterol, which is the one that's in your bloodstream, not in every cell that we talked about, is the factor that can cause our heart disease and stroke. So that's the one that we can modify, is the one that actually is just swimming around in our bloodstream.
Yeah. That's a really, really important point, so I'm going to emphasize it. Every cell in our body can make cholesterol from scratch, except our eyelashes. And so the cholesterol in your blood is the extra stuff. So I've heard a lot of patients say, well, don't I need cholesterol? Absolutely, but you don't need it in the blood. That's the extra stuff that your body's making that it's trying to get rid of. So you probably heard the terms the good and bad cholesterol, and I'm going to spend a little time explaining what that means. The good cholesterol is called HDL, or high-density lipoprotein. And the best way to think about this is that cholesterol is a fat, and your blood is mostly liquid. So your body needs a way to transmit your cholesterol excess from one part of your body to another. And the place in the body where you get rid of the cholesterol excess is your liver. So when you have extra cholesterol production from other cells, it goes into the bloodstream, and because fat and water don't mix very well, you need to create proteins and other ways for these molecules to get from different parts of the body to other parts of the body. So the HDL is a very favorable orientation of those fats and protein. LDL, on the other hand, is an unfavorable combination of fats and protein. So whereas HDL at high concentrations tends to cause less atherosclerosis, LDL in high concentrations causes more atherosclerosis. And in fact, because of the fact that it's important to get rid of the LDL, the bad cholesterol, you actually have receptors in your liver called LDL receptors that are responsible for identifying those LDL molecules and removing them from your circulation. So those are called LDL receptors. Now, the fact is that this is your overall cholesterol pool, and cholesterol as a molecule can move from these larger particles. So we use the word particles to talk about LDL and HDL because they're these massive molecules that have cholesterol in them. And cholesterol moves between these particles. And there's a formula that relates all these different particles, which is the formula on the bottom that we use all the time. It's called the Friedewald equation. And so when you go to your doctor's office, chances are you're not having your LDL measured, but you're actually having it calculated. And LDL equals your total cholesterol minus your HDL minus your triglycerides divided by 5. And so a nice trick that I like to show off with people when patients come into my office is I can predict what their LDL is if they just give me what their total cholesterol is and their HDL, and I just ask them how high their triglycerides are, and they're kind of amazed at how I can figure that out. But it's a very simple formula. Mm-hmm. Don't tell anybody my tricks.
Wizardry.
So go ahead, Vicki.
So we talked about the things that you could do, such as diet, controlling your diabetes, smoking, getting regular exercise. Those are all things that are what's called modifiable risk factors. Those are things that lower that cholesterol swimming around in your blood vessels, which is the one that causes the damage. But you also have genetic issues that can affect it. Family history can affect it. Your gender can affect it. Ethnicity, your age. I'm not sure the weather really affects it, but you know it could. Seems to affect everything else. And again, the key is this is the cholesterol that's swimming around in our bloodstream that we need to do something with. We've got to get it to the cleaning source, which is the liver. We've got to be able to get rid of the specific one that's bad and hang on to the one that is good. And that's where a lot of the research has been, is identifying these LDLs that we want to get rid of and what they're made of and how to get them out of the system.
Yeah, weather might seem funny, and it may be a little funny, but the fact is that if the weather is horrible and you're indoors all the time and not active, it can actually affect your heart disease risk.
And you're eating poorly because of it. Mm-hmm.
Yeah, and there are other studies that have shown that the stress of natural phenomena, like hurricanes or earthquakes and things like that, actually cause heart attacks and sudden cardiac death. So it is definitely a non-modifiable risk factor when you think about it that way. So let's talk about some of the genetic factors that we can't change, and actually talk about the fact that maybe that's no longer true. You know, one of the breakthroughs of science could actually be that things that were previously not addressable can now be addressed. So let's just ask everybody their familiarity with these things. Which of these conditions is a genetic lipid problem? Familial hypercholesterolemia, elevated lipoprotein little a, alien invasions, answers 1 and 2, or all the above. So this is more like an SAT question. So now you guys are experts, so we're making it a little bit more difficult. So who says number 1? Okay. Who says number 2? Who says number 3? Please, no hands up for that one. Who says number 4? Okay. And who says 5? Okay, so you guys are smart. Yep. The answer is 1 and 2. So we'll talk about both these things, familial hypercholesterolemia and elevated lipoprotein A. So familial hypercholesterolemia is actually a very common genetic disorder. It affects, depending on what part of the world you live in, between 1 in 250 and 1 in 500 people. It's interesting. It's prevalent in certain populations, like in South Africa. It's prevalent in Quebec, in French-Canadian areas, and it's prevalent in Holland. So those are some places where you see very high incidence of it. But in most populations, it's about 1 in 500. There's 3 ways you can develop this problem. I mentioned the LDL receptor, which is that part of the liver that's responsible for removing cholesterol from the circulation. If there is a genetic defect in that receptor, then your body can't get rid of the excess cholesterol. So that's one form. There's something called ApoB defect. Apolipoprotein B is the protein that's responsible for allowing the LDL molecule to move in the circulation, as I described. It's the protein part of the lipoprotein. And if that's not working well, then that LDL molecule can't be targeted to the LDL receptor. The LDL receptor is looking for a certain configuration of the ApoB in order for it to grab onto an LDL molecule and get out of the circulation. So if there's a defect in the ApoB part of LDL, you'll have a big problem. And then the one that was just most recently identified is called PCSK9. And PCSK9 is a circulating protein that actually impairs the ability of the LDL receptor to work. And some people have extremely high levels of PCSK9 naturally for some reasons, and their LDL receptors are less numerous and have more trouble removing cholesterol. Whereas some people are born without PCSK9. This is an interesting area where we actually learned about this genetic problem because there's certain populations that don't make PCSK9 because of a genetic issue. We won't call it a defect, a genetic issue. And people that don't make PCSK9 don't get atherosclerosis. They live their lives with really low LDL levels, like 15 or 20, and they don't get heart disease, and they seem to do very, very well. So when people discovered these genetic changes, they were able to piece together the fact that PCSK9 is a very important protein in LDL metabolism. The other thing to know is that if you have a gene from one parent or 2 parents, that makes a big difference. So in heterozygous familial hypercholesterolemia, which is the most common form of familial hypercholesterolemia, or FH, you get the gene from one parent. It's autosomal dominant, meaning that if your parent has the condition, you have a 50% chance of getting it, and your siblings have a 50% chance of getting it. Homozygous familial hypercholesterolemia is when you get 2 of the exact same gene from your parents. So you can imagine that would be really, really rare, because unless your parents brother and sister, chances are that you're not going to have that issue. But it happens every once in a while that you just happen to have 2 parents that have the exact same genetic defect, and that leads to this really devastating condition where you start to get heart disease as a toddler, literally. And then what's called compound heterozygote means that you have 2 genes that are problematic, but they're different genes. So you still tend to have severe atherosclerosis, but it's not quite as bad as homozygous familial hypercholesterolemia. And people that are diagnosed with this condition will typically start to develop complications in their 20s and 30s if they're men, and in their 30s and 40s if they're women. So it's a very severe problem, and something that should be identified, hopefully in teenage years, so that we can intervene. Another familial condition is called familial hypertriglyceridemia, or FHTG. This is also an inherited condition, and it's marked by having levels of serum triglycerides that typically are above 500. Every once in a while you'll see people that are in the 200 to 300 range, but more often than not, they'll have periods of time where their triglycerides are in excess of 500. This is related to the liver secreting triglyceride-rich very low density lipoprotein. VLDL is a little different than LDL and HDL, but it's the type of lipid particle that has the most triglycerides in it. And this is associated with obesity, and it's also associated with diabetes or glucose intolerance. And one of the concerns about this particular condition is it can be associated with pancreatitis. The pancreas can be damaged by the high levels of triglycerides, and that's a nasty condition. That's a condition where you can have very, very severe pain. It tends to be recurrent, and it takes a long time to recover from it. So we actually are just as concerned about pancreas protection as cardiovascular protection when somebody has a triglyceride problem. The other one that we're really excited about from the standpoint that we are now able to do something about it is called lipoprotein little a. And lipoprotein little a we like to call the evil twin of LDL. And the reason we call it that is because it's actually an LDL molecule plus. So if you look on the right side of the slide, you'll see a spherical mass there, which represents LDL. And lipoprotein little a is a combination of that mass, the LDL, plus that little squiggly thing on the outside of it, which is actually a type of protein, which is why lipoprotein A has its name. That's the protein part of lipoprotein little a. And then you'll see a little purple thing at the end, which is another molecule called plasminogen. And plasminogen is a molecule that's actually involved in the clotting system. So this particular molecule is really interesting because most people have pretty low levels of it. But there's about 20% of the population that have much, much higher levels than everybody else. And typically those people have a family history of heart disease. And we think that they may be at particular risk for heart disease because there's a combination of having the LDL with that particle that's responsible for clotting or lack of clotting. And that combination is a bad combination. So if your clotting system is hyperactive and you have more cholesterol around than you should, that's probably a bad combination that leads to blood vessel complications. So LPA, we call it triple threat. It is pro-atherogenic, meaning a higher risk of heart attack or stroke. It's pro-thrombotic, it causes blood clots, and it's pro-inflammatory. So it's an important risk factor for cardiovascular disease. So let me pass it off to Vicki to talk about some of the therapies we have.
So the most common one is the statins, and we talked about people who were lipid virgins after having heart attack versus having been on them before, lipid-lowering medicines, and this is one of the most common ones, one of the first ones, and they work in the liver. And what they do is they block that enzyme, HMG-CoA reductase, and that helps the body to recognize those cholesterol molecules. Remember, we talked about they need to recognize it, they need to get it, and then they need to clear those molecules out of there. And these are some of the names that you've probably heard of various people being on various ones of these lipid-lowering molecules.
Yeah, we're proud of atorvastatin and Lipitor around here because our center was very involved in the development of that product back in the early 1990s. And for many, many years, Lipitor was the #1 selling drug in the world. And it was interesting because it was actually the 5th statin to get to the market. But because it was more effective than the other statins, and because the clinical trials that were created and conducted were very original, it actually became the #1 selling drug in the world. So it's a good example that clinical research makes a difference, not only in terms of helping people and reducing heart attacks and strokes, but also selling products if you are able to get people involved in really good clinical trials.
I'll let you address these.
Sure. And these are some of the other products on the market that help lower cholesterol or treat lipid problems. And lipid is just a term for blood fat, just to remind everybody. So ezetimibe, or a drug called Zetia, reduces cholesterol absorption, and we often use it in conjunction with statins, or we use it for people that have a hard time tolerating statins at their full doses. The good news about that is that it does help reduce heart attacks and strokes for people who have already had one. The less good news is that it only has a relatively modest effect. It only lowers LDL another 15 or 18%. They have something called bile acid resins, and what that does is it interferes with the body's ability to reabsorb cholesterol. So as I mentioned, when your liver gets cholesterol out of your circulation, it removes it from the body by putting it into your intestines. But once it gets into the intestines, it can be reabsorbed again. So the resins prevent that reabsorption from occurring. Vitamins can sometimes help. The one that is most well known for that effect is niacin, or vitamin B3. It lowers LDL, it boosts HDL, and reduces triglycerides. There was studies done in the 70s that showed that niacin actually can prolong life in people with coronary disease. But we've been a little disappointed with niacin lately because it doesn't seem to add anything to statins. So statins work much better than niacin, and when you add niacin to statins, you really don't see much. And interestingly, even though niacin is just a vitamin, it can actually be pretty rough on your liver. So we're also careful about that. But it still has its role in certain circumstances. Fibrates is another class of drugs that lowers triglycerides and can raise HDL. Again, usually used for people that have familial hypertriglyceridemia or other very high triglyceride states. It's not used for routine cholesterol problems quite as much. Then you have a new drug that we were involved with, its development here, called bempedoic acid, and it's a new class called the cholesterol biosynthesis inhibitors. And I mentioned the PCSK9 inhibitors, which are a remarkably cool class that actually use monoclonal antibodies to block this bad protein called PCSK9 that I mentioned. And we'll look at that in a second. So we got a question. Yes?
Another alternative, what do you feel about bergamot? How does that fit into helping to lower the cholesterol?
You're talking about the supplement?
Yes.
Yeah. So there's a lot of different supplements out there that can help with cholesterol lowering, and I'll address this more in the question and answer session. But the biggest difference between the drugs that we're talking about and a lot of supplements is the amount of data that we have to show exactly how they work and how effective they are. So there's actually some very interesting science with nutraceuticals and other things that I'm very fascinated by, but they tend to not have the huge databases that we have for the drugs that we mentioned. So anybody want to guess about this? What do COVID vaccines and the new cholesterol treatments have in common? This is a tough question.
They're both helping to reduce death, right?
That's good. I like that. That's a good answer. Excellent answer.
They're both lipids?
The COVID vaccines, the messenger RNA vaccines actually are in these little lipid micelles or nanoparticles, but that's a little bit different than the lipids we're talking about. Yeah. Anyhow, I guess I'll jump in, is that they're using these new biological technologies often surrounding RNA. You've probably heard the term RNA. It reminds you of high school or college biology. And RNA is the molecule that takes the genetic instructions from DNA and tells the body, usually the ribosomes, what to do with those instructions. Basically, RNA it's like an email.
Mm-hmm.
It's the way our body emails. It says, okay, the nucleus has some work it's got to do. I'm going to send out this email. Boom, the messenger RNA goes out there, and it says, okay, make this protein.
I have a little bit different way of explaining it. Every one of our cells has in our nucleus, which you also probably remember from biology, all of our DNA. So every cell has all of our DNA in it, and we'll consider that the recipe book. The RNA is the recipe for that specific cell, what it's going to tell that cell to make. So the nucleus says, I want you to make a muscle cell, and it sends out the recipe, the RNA, for muscle cell, and the ribosomes, the little factory, makes more muscle cell. And so all throughout our body, we have our big recipe book, and the recipe that is going to be made by any part of our body is that messenger RNA.
Yeah, that's a nice way to express it. Yeah, the reason I like to use the email analogy is because DNA sticks around forever, but RNA is transient.
Right.
So our body breaks down RNA very, very quickly. So it's kind of an email that, okay, you read it and you delete it.
Mm-hmm.
Read it, you delete it. You read it and delete it. But there are ways of now manipulating RNA in our bodies that can have huge therapeutic differences. So in the last 5 years or so, there have been several products that have been approved that are using these newer biological technologies. And we're just going to spend a little bit of time studying them a little bit more closely, particularly because there are actually studies in our community that are looking at these products. So as we speak, We have volunteers that are in our center that are volunteering to be part of these programs. And of course, if you know of somebody that might benefit, we'd be more than happy to look at them and see if they're a good candidate. So just to help people visualize these things, it's kind of a bit of a vague concept, and sometimes it helps to see some pictures to visualize it. So we mentioned the PCSK9 antibodies. There are two that are approved on the market, and we were very involved in the development of both of those and did some critical studies for both these products. They're called Repatha and Praluent. Has people heard that? They're advertised pretty widely. And the way they work is, and it's really miraculous. I've seen the labs where they do these things, and it's mind-boggling. But basically, they take mice that have human genes, and they develop antibodies against a particular antigen. And through this very complex process, they're able to take these antibodies that will target that bad antigen of protein and nothing else. Pretty cool. So,
How much does that mouse cost?
more than my salary.
But that's also how vaccines work. When you get an injection of just a part of the COVID vaccine, whether it's the spike protein or the messenger RNA that they inject into your muscle that tell your muscle to make the COVID-19, it's an antigen, it's something foreign, it's an alien. And then our body makes antibodies to it. And then we store those. And then the next time that comes into our system, we attack it. So these antibodies are attacking something we don't want. We tell it what it is we don't want, and there are army men that are specific for that. They're snipers for that situation only, that entity only.
Yeah, and to answer your question, I've heard, I don't know if this is substantiated or not, but that when the people that have that technology want to license out the technology, they charge $250 million for the mice. That's what I've heard. Now, I tried to sneak one out of the lab, but I got wrestled to the ground.
Is that what Socrates did to go to jail?
Yeah, exactly.
Stole a mouse?
So some other technologies that are out there is called antisense oligonucleotides. And these are ways of neutralizing RNA. So think of the monoclonal antibodies as a way of sopping up the bad guys once they're in the circulation. So you have these antibodies that are looking around the circulation, the bloodstream, and when they see a bad guy, they grab onto it and they neutralize it. But this technology actually gets into the cell and says, okay, we're not going to even make this protein in the first place. So it's a way of identifying the target RNA that you can see on the right side of the slide with something that's predefined to match that perfectly.
Left side. Here's the target RNA.
Okay. They're right.
That's their left.
All right. Anyway,
It says high IQ people, you
yeah,
know.
yeah, what can I say? A little dyslexia here. Anyhow, so the target RNA is identified and then neutralized by the antisense oligonucleotide. Another technology that does this is called small interfering RNA. And this is really, really cool, and also kind of related to COVID, in that this is how our body naturally fights viruses. So viruses, as you know, can be either DNA or RNA, and we actually have intrinsic mechanisms in our body to identify pieces of RNA that are foreign. And so with this technology, we use that particular capability of our body, and we create neutralizing pieces of RNA that goes into the cells and doesn't allow these bad proteins to be made. So really, really cool stuff, and studies that we are doing here as we speak. And another class that's really, really interesting is called adnectins. So as I mentioned, the monoclonal antibodies are an amazing technology, but they're very expensive and very costly to make. And adnectins are a little bit simpler to make because they use the fact that you can use basically a chunk of human serum albumin and then tie to that chunk of albumin the specific coding for the protein you're trying to neutralize. So instead of building a complicated monoclonal antibody in mice and having to grow that, it's easier to just take albumin and create this molecule that also will specifically target a bad antigen. And as we speak, we're doing studies in this community that's using this technology to help people that have high cholesterol. So I'll mention that we are in a place in Florida that is around average in terms of heart disease, But the map around the country is, shows you that in the, quote, deep south, you have the highest risk of age-adjusted heart disease death, and also in the Midwest. So maybe the coldest places and the hottest places are the places that are the ones that are most affected, plus probably dietary differences. But nonetheless, as mentioned, this is a nationwide and a worldwide problem and phenomenon. So we're excited that we are actually part of the solution. Go ahead, Vicki. Why don't you tell us about some lifestyle issues?
So earlier we talked about the modifiable, the things that you can in fact do and to prevent another heart attack or prevent a heart attack altogether. And you can work on optimal weights and heart-healthy diet, Mediterranean as the nuts and seafood, high fiber, and pure. Stopping smoking, managing blood sugars and blood pressure. Regular exercise is going to help with the weight. It's also going to help with blood sugar and blood pressure. So again, those are the things that not only can help prevent a second heart attack, but can prevent one to begin with and do some things to help your overall health, even if you have one of these genetic conditions that we're talking about all of these fancy experiments for. And again, this is more of something that can modify the risk of another heart attack. Taking daily aspirin could help.
Well, we'll do a show of hands. We'll get the audience involved here. So raise your hand if you think that this is helpful to prevent a second heart attack. Daily aspirin? Okay. Statins? Okay. We're with you. Ezetimibe? People not sure about that? Yeah, we'll vote for ezetimibe. PCSK9 inhibitors? Absolutely. Studies that were done here actually relatively recently. Icosapent ethyl? The answer is yes. A Mediterranean diet? Absolutely. All the above. All right. So we're going to end this with just sort of a typical patient that I see in my practice, and then we're going to go to audience questions. But these are the type of things that you might want to think about if you're either this person or like this person or know somebody like this person or maybe have some similar story. So this is a 61-year-old male who is a bit of a health nut. He's a professional writer, likes to do a lot of research, and really smart guy. And he's been hiding away because of the COVID pandemic, mostly indoors, so not exercising as much as he might like. He has a very strong history of heart disease. His father had a heart attack and died of congestive heart failure in his early 60s. And he recently experienced this weird jaw pain when he finally got the courage to go outside and walk up the steep hill in San Francisco. So he was advised to see a cardiologist, which he did. He got these lipid panel results, LDL 115, HDL 59, triglycerides 68, and then had a stress test that was, quote, mildly abnormal. So this is the type of people that we help at the center, people that can have this type of profile, that have some concerns, have some family history, and help them understand whether or not they have genetic factors or do they have factors that can be addressed otherwise. And just to give you a couple of quick tidbits, obviously that LDL can be worked on with statins, but the history from his family is one that he would need some more sophisticated testing in order to figure out. And we're certainly here to help with that. So in the interest of time, I'm going to just remind everybody that we have these educational sessions on a regular basis. If you're interested, give us a call. Maybe you can make it to our live studio audience. It's harder to get in here than Saturday Night Live, I think?
Yes, yeah.
It's a little bit harder,
A lot
isn't it?
fewer people are allowed to get in.
Absolutely.
Got to pass our rigorous testing.
Yeah, the screening is much more difficult
Yes,
here.
it's actual tests.
Yeah, absolutely, yeah. And is the alcohol content of the audience higher or lower than Saturday Night Live audience?
Well, it's a little higher when it's a little later in the day.
Okay, all
They're
right.
just starting out right now.
Are we doing the drug screens?
No,
Okay, good.
we're turning a blind eye to
All
that.
One event, we'd love to have you come participate in a future event, and now's a good time for questions. We'll start with the live audience. Any burning questions before we get to the Zoomosphere? Yes, sir.
Yeah, it's not so much as a question per se, but I'm familiar with the statins, as far as the cholesterol preventing medications, and But just last night I was reading about the resins, and they listed another category of medical, pharmaceutical, medicines on that category. But I never really heard of the resins before, but I heard of the statins.
Sure.
And I'm kind of glad, I'm glad you cleared that up for me today.
Sure.
That helped.
Yeah, the resins are sort of like ezetimibe in that they lower LDL only about 15%, because as we mentioned, that's only the cholesterol that's being reabsorbed. Most of the cholesterol in your circulation is actually coming from the cells. So they do work. We use them, but they're a bit modest in terms of their impact. Yes, ma'am.
Let's just say if you could predict the future, where do you think we'll be in about 5 years?
Is your crystal ball working this week? No? Well,
Battery's dead.
battery's dead? Okay.
I'm looking for a solar panel.
But we need one. Yeah, we need one. Well, it's a great question, and I think with these biologics that are being developed, we will routinely be able to get LDL cholesterol down to levels we've never seen before. So with drugs like Repatha and Praluent, which are on the market, and some of the other drugs that we're using in clinical trials, we can get LDL levels down to 10, 15, 20, like unbelievably low levels. And we know that when LDL gets that low, you can actually regress blockages in the arteries. So if I had to predict the future, I think the recommendations will be to get lower and lower and lower and lower, and we'll have better tools to do that. Yes, sir.
About predicting the future. With COVID, a lot of people were changing their diet, getting food brought in, eating more fast foods, weren't going to the store as much, and didn't get as much exercise because some people were worried about coming into contact with people. Do you think, well, you said before that there was a stable level of cardiovascular disease death, mortality. Do you think that will rise in 2021 because of residual effects, or do you think with the vaccine they'll be able to offset that?
What do you think?
Well, since we know that the opposites tend to reduce, you can hypothesize that yes, that in fact would raise the risk of it. We know that there's been an increase in stress, and we talked about how stress can result in heart attacks. We know that there's been an increase in weight gain. Now there's been a sudden increase in people applying and signing up to go to the gyms, et cetera. But the gyms, of course, that's you go for 4 weeks and don't go back unless you're pretty religious about it. So I would hypothesize that that is going to be a factor. And like you said, there are people who have gotten more deliveries of food, but on the opposite, believe it or not, grocery stores have actually been doing a booming business because people are cooking at home. The question is, are they cooking at home and making healthier foods per se? The frozen food sections has been the biggest growth, and so those aren't necessarily your healthiest foods. So.
Yeah, and the slide we showed earlier showed that in 2020, heart disease deaths went up. And we are concerned that will be an ongoing trend, but we'll see. In 2020, one of the issues was that people were afraid to actually go to the hospital. They're afraid to get COVID in the hospital.
Right.
So they were suffering at home and sometimes dying at home. I think we have some audience questions. Go ahead.
Yeah, we have an audience question from YouTube. She asked, how can you tell the difference between the suffocating feeling of anxiety and angina?
Go to medical school for 12 years? Do you want to jump in?
If she's a female, she should not leave it up to herself to make that decision. And if she's having that choking, suffocating feeling and is not sure, even if she has anxiety, she should, as we showed with our health nut, go and see a cardiologist and have that evaluation done, have those EKG done, et cetera, have those labs drawn to look at her breakdown of her lipids.
And I would emphasize that point that if you have a suffocating feeling, get help. EMS can come out and help you. You can go to a hospital and help you. You can go to a doctor's office. Just getting an EKG gives us a lot of information. EKG is not perfect, but if you're having a major heart attack, it'll show up.
Thank you.
Any other questions? Yes, sir.
Yes, I was kind of surprised at your answer concerning that women have more heart attacks or recurring heart attacks than men, due to the fact that, I looked at it that the longevity of women, they live 5 to 6 years longer than men as far as their lifespan. So from that, I interpreted that, well, maybe men would be having more heart attacks or reoccurrence of heart attacks.
They're just more deadly when they have them because their vessels are not as resilient as ours. And we have smaller heart attacks, if you will, so we don't get the interventions to reverse the process as soon as a man might get the interventions that can potentially reverse the processes.
And just to be clear, that's recurrent heart attacks.
Recurrent.
Not first heart attacks. So men still have more first heart attacks than women. But the nature of coronary disease is different. But heart disease is the #1 killer in both men and in women. Women tend to have heart disease about 10 years later than men, probably because of protective effect of estrogen. Yes, ma'am.
So you touched on where I was going to go with that, because you mentioned that in women it tends to happen after menopause and the hormonal changes that occur with menopause. Are we finding that hormone therapy is helping or hindering or not having a factor at all?
Yeah, great question about hormone therapy. There was a, when I got out of medical school and did my residency, we thought that hormone replacement therapy was something good for postmenopausal women, and that has changed. We now have studies that show that it really does not make a difference for cardiovascular disease. There are other reasons that we use it.
Yeah, I mean, it doesn't help that much with cardiovascular disease, and there's actually been many more studies that have been done that beyond the 5 or 6 year post-menopause can actually be dangerous. And so that's a big ongoing to use it by mouth versus to just use it for the symptomatology of the other things that estrogen deficiency can cause. But as far as the cardiovascular one, it wasn't much of an effect, so it's not recommended routinely.
And over time, the differences between men and women in terms of incidence of heart disease has changed. So, 40 years ago, men were much, much more likely to get heart disease than women, but that's kind of evened out for a number of reasons. One is that women smoke more. They smoke just as much as men. That wasn't the case 40 years ago. Diets, women probably had better diets overall than men, and maybe that difference is narrowing as well. So there's a lot of socioeconomic factors as well as hormonal factors that are important. Question?
These medications that are causing the liver cells to uptake more cholesterol, how does that impact a person's liver as far as function goes?
Good question.
Yeah, really good question. So any drug can affect the liver, and any drug that treats cholesterol can potentially affect the liver. But statins, which were thought to maybe have some significant side effects with the liver, turn out to actually help the liver in a lot of cases. And the reason for that is because when you use these drugs, they upregulate something called the LDL receptor. And the LDL receptor is an important part of the way the liver does its job. So in many cases, we're actually using drugs that enhance the function of the liver. And it's believed now that drugs like statins and probably the PCSK9 drugs and others will help the liver by reducing fats, by helping the liver do its job of getting fats out of the body that in turn can't deposit themselves back into the liver. So while we're always looking at liver issues when we develop new drugs, we think on average cholesterol-lowering drugs should have more benefits to the liver rather than risks. So I think we have time for one last question, and you will be the lucky one.
The connection to the fatty liver diagnosis, which I saw on Facebook when your information was there, is that similar to what you're talking about, that the statins will just reverse the fatty liver condition?
Okay, that question was not a plant, but next week we'll be talking about NASH, which is non-alcoholic steatohepatitis, NASH, non-alcoholic steatohepatitis. That's basically fatty liver disease. The #1 cause of liver transplants in the United States now is not hepatitis, it's not alcohol, it's fatty liver. And it's a very, very active area of research. And there's actually a connection between cholesterol treatment and fatty liver treatment because of exactly what I just said, that a lot of the cholesterol treatments help get fat out of the body, including getting fat out of the liver. So thank you for that question.
You're welcome. Thank you for that answer.
You guys are great. Thank you so much for being a great audience. We appreciate it. And we look forward to seeing you again.
All right.